Your smartphone is already an amazing device, and it may soon play a role in helping you identify the earliest symptoms of Alzheimer's disease. Let's learn more about that today. I'm Lee Kelso. This is HealthCall Online, the place for extended versions of interviews you hear on our weekly radio broadcast, the HealthCall Radio Hour. Dr. Gad Marshall is the Director of Clinical Trials, the Center for Alzheimer's Research and Treatment at Brigham and Women's Hospital. He's also an Associate Professor of Neurology at Harvard Medical School, and he's involved in some trials right now trying to find how drugs that modify proteins in the brain and whether that slows progression of Alzheimer's. And we'll find out how a cell phone could play into all of that. So, Dr. Marshall, thanks for being here. Appreciate you taking the time.
Thank you very much for having me.
All right, let's start by explaining why this is important, and then we'll talk about how this research is progressing and what it may lead to. So what makes it so critical to spot Alzheimer's at its earliest opportunity?
Sure. Well, currently the treatments that we have available on the market are targeting people already are at the stage of dementia and provide a modest improvement in symptoms, and then they wear off pretty quickly after 6 to 12 months. We are on the cusp of having new drugs approved by the FDA that may slow down the progression of disease, but still pretty modest in benefit. And so we're hopeful that if we go earlier in the disease, before you have symptoms, at a stage that we would consider preclinical, where you have evidence of pathology of disease but no symptoms yet, you may in fact make a bigger difference in terms of really preventing symptoms from occurring or really slowing it down significantly.
So it's very much like cancer. The sooner you discover the disease, the better your chances of a positive outcome.
Yes, certainly. That's the direction we want to follow. We still have a long way to go, but that's correct.
There's something called the Harvard Automated Phone Test that's been widely accepted. And can you tell us how that works and how that plays into your research?
Sure. So this is an assessment that we developed several years ago at Brigham and Mass General in conjunction with a company called ADK. That's a and a company called Wipro. That's a New York-based company. And it is a slice of assessment of daily functioning. We typically assess individuals who may have Alzheimer's disease or at risk for it with cognitive assessments of their memory, thinking abilities. But we ultimately want to know if they're functioning in their daily routine. And so this is a way to assess that and a way to do it in a more sensitive fashion than we've typically done, which is a questionnaire that is administered to somebody who knows that individual well, but typically doesn't pick up early symptoms of change in daily functioning. And so what we do here is we developed a phone task where the individual navigates a phone menu to perform a number of tasks, refilling a prescription, calling a primary care physician, calling a health insurance company to select a new primary care physician, things of that sort, which can be done directly by the individual. And so a more objective assessment of their daily functioning. The scores that we get are more nuanced. And so we can detect very early changes in daily functioning that may be more meaningful to individuals. And so that's the idea behind this assessment. And we've done several studies to validate it. And most recently, I've looked at it with measures of pathology of Alzheimer's disease, which we can discuss further.
Yeah, so in other words, how many mistakes I make, how long I am delaying and making choices in this phone tree tasks, those kinds of factors are clues. And then I understand you went back and took a look into the pathology and sampled to look for these amyloid and tau proteins. Tell me about that.
Yeah, so in our most recent study, we were able to look at individuals who are cognitively normal, who are older adults, and they may be at risk for developing Alzheimer's disease, but we're not sure about that. And so to determine their risk, we performed multiple scans of their brain, and 2 of the scans looked at the typical pathology of Alzheimer's disease, so protein abnormalities that are called amyloid and tau. So the amyloid is deposited as a plaque in the brains of Alzheimer's patients, and tau is typically normally found in their brains and the nerve cells, but becomes abnormal in Alzheimer's disease and leads to the nerves degenerating and dying. And so we're able to measure those with scans called PET scans of the brain, and that's what we did in this cohort, and then compared it to the phone task.
And you then confirmed that, yes, the phone test is an accurate way. People with elevated levels of these proteins do score more poorly.
Correct. And so especially for the more complicated tasks, we saw that relationship in these individuals.
So where does that lead us then? What does that tell us about how we could use the smartphone in the future?
Right. So the idea here is that we'd be able to detect very early changes in daily functioning in people who don't have symptoms yet of Alzheimer's disease, but have evidence of pathology. And so this is what we're doing now in prevention trials for Alzheimer's disease, but we don't have as many assessments that are sensitive for daily functioning. And so the advantage here is of collecting this early on and being able to understand what the changes are in daily functioning. And then later on, if there's more decline, use the more typical assessments that we've used in the past.
So is your thinking that I would, if I'm concerned, I load a cell phone app on my device and periodically test myself, and the scores then are reported someplace and I get an assessment that way?
Well, so this particular test, just to clarify, is not an app. It's using a regular phone. We do have a new assessment that is using a smartphone that is in fact an app that is looking at other tasks that relate to daily functioning that are actually kind of medical or medically related in terms of performing different activities that relate to your healthcare, navigating a patient portal, and so forth. Regardless, either of these assessments will give us an idea of how you're functioning now, and we can measure them over time to see if there is a change in your daily functioning. They are currently in the research setting. They're not being used clinically. If we are able to look at these in a multi-center study where we can see that they're still they're reliable in terms of how they perform in such a setting, I think we will be able to move to potentially the clinical setting. And this is something that could be self-completed, correct? And so you could get an idea of how you're doing over time. Certainly, if you have a primary care physician who does not have the expertise of assessing your daily functioning or the time, sadly, then this is something you could perform on your own and then provide the scores to the provider who can discuss them with you.
When I talk to people about Alzheimer's and their concerns, many times they ask, okay, so I know if I just sort of forget where I put my keys, that's not a big deal. Can you tell me what is a big deal? What are we talking about here in terms of behaviors that should be warning signs or triggers of concern?
Sure. So the key changes are consistent changes that are getting worse over time. And so if every now and then you forget something, either misplace an item or forget a name or forget a word, generally that's not something that we're as concerned about. If you walk into a room and you forgot why you walked in there, it's not something we're as concerned about. On the other hand, if you do consistently forget recent events or details of such events, you forget to pass on messages that were given to you, you start repeating yourself more often, you are getting lost in locations that are pretty familiar to you, you have difficulties managing, say, your medications because you have a new medication, you just forget to take it because you're only used to your routine. These are a variety of examples of things that could be more concerning and could be suggestive of decline that needs to be addressed.
Yeah, I heard one example. It's not forgetting the car keys that's the worry. It's forgetting what the car keys do and how to use them. That's the more significant concern.
Yeah, certainly. I mean, that level of procedural memory difficulty is certainly much more concerning if you have that difficulty.
So now we're at the cusp of approval of a couple of new drugs that are designed to call my body's attention to these proteins in the brain. They're calling the immune system to come into the fight. And so one of the big challenges with identifying people who are able to receive these medications is who is eligible. How are we going to determine that criteria? What's your thinking on how that's all going to play out in the next year or so as these meds just now get FDA approval?
Sure. Yeah. So the first one coming up hopefully in the next 3 days, lecanemab, it will really change the landscape of how we treat patients with Alzheimer's disease. It is a very different type of drug from what we're used to. It is not a pill. And it's infused through an IV. In this case, every 2 weeks. It requires a lot of monitoring for safety with repeat MRI scans, making sure you don't have side effects that sometimes are only noted on MRI scans. And there are also more elements in terms of determining who's eligible, as you suggested. So it is not purely based on the clinical assessment as we've typically done with the prior medications that have been approved. We actually need to know that you have an abnormal amount of amyloid in your brain, because that is in fact what these drugs are targeting. And we know that at the stage that they're targeting of either mild cognitive impairment or mild dementia, we combine that population, only about 65% of individuals have the elevated amyloid in their brain. And so we need to have a test for that done before we proceed. And that can be done either with one of those PET scans, which currently is not covered by insurance yet, by Medicare, although there is a push for Medicare to cover it now that there will be a drug that influences amyloid, or alternatively doing a spinal tap and look at the spinal fluid. There's one more complication that we know, that a certain gene that increases risk of Alzheimer's disease, the ApoE gene or apolipoprotein E, when it's expressed a certain way that increases risk, it also increases risk of the side effects of this drug and similar drugs. And so we'd recommend testing for that gene in order to better inform the patients and their families about the risk from the drug. And so not a straightforward direction, but encouraging in terms of knowing that there is a way to potentially slow down the progression, and maybe this will open it up to either more effective drugs in the same class, or maybe combining them with other drugs targeting other pathologies in the brain that then will give us a better effect altogether.
I'm sure you've been intimately involved in watching this research, if not conducting it yourself. How much of an improvement are you detecting in patients?
Yeah, so we're not detecting an improvement with these drugs. We're seeing a slowing of decline. So that is a difference from the prior drugs that have been approved by the FDA, where they improve symptoms modestly and then they wear off. In this case, we see a modest slowing of decline. In particular, with lecanemab, we see across the different tests that were done about a 30% chance of, about a 30% slowing of decline over time, over 18 months. It was the duration of the trial. That could be also interpreted as about a 6 to 7 month period of gaining, or I shouldn't say gaining, but not losing ground as much over those 6 to 7 months. So not necessarily a slam dunk, but does give you something.
So you're taking your foot off the gas of Alzheimer's progression, essentially, with these medications.
Correct.
And the expectation then is, since the trials were only 18 months, do we know what happens? If we stay on these drugs longer, are we going to see accelerated benefit or just the same?
Right. So the quick answer is we don't know, because the longer exposure to these drugs and these cohorts were not compared to placebo. And so they were continued for everybody, though. So people who were on the placebo part before moved on to get the drug for sure after the 18 months. And so you don't know for sure if the slowing continues or wears off. And that's an important question, which we will try to answer from our clinical use of the drug. But again, that will not be compared to a placebo. On the other hand, there are prevention trials that are ongoing with lecanemab, and donanemab is the other drug that's also moving in the direction of approval because of positive results in people with symptoms of Alzheimer's disease. So there are two prevention trials with both of these drugs that are ongoing that will have longer follow-up, and of course will be earlier in the disease process before you have symptoms. And so it won't be a direct answer to your question, but it will give us an idea about duration of effect potentially.
Couple of I guess we'll call them lightning round questions. How about that, real quick? We've talked a lot about the protein deposition theory for Alzheimer's, the tau and the amyloid plaques. What's your taking on neuroinflammation as potential cause of dementia and Alzheimer's?
Yeah, well, so I think that it is an important mechanism. We do have a lot of evidence from the laboratory setting that neuroinflammation can lead to neurodegeneration as a broad process. It has been a very challenging mechanism to tackle in a clinical setting in human beings. So when we're testing different anti-inflammatory agents to treat individuals who have symptoms or are at risk of symptoms of Alzheimer's disease, we have not had success, and we have not necessarily had as selective drugs for that. And so it's potentially that we're just targeting inflammation generally, and we're not targeting select inflammation in the brain. And so that's been a harder mechanism to target over the years. But I think that we need to keep at it, because at least there's evidence from the lab setting, and so I think we still have a ways to go with that.
We recently talked with a researcher at Duke who indicated exposure to HSV, the herpes simplex virus, in brain tissue in the Petri dish resulted in the beginning of the formation of the amyloid plaques. What's your thinking on the viral theory of Alzheimer's?
Yeah, so there's been on and off, a lot of research going on in this area, and it's been accelerating again recently, and a lot of different viruses have been looked at, even some bacteria in terms of flora that you can have in your mouth. And the quick answer is that it looks like in the lab setting, again, this kind of triggers a cascade that would actually lead to inflammation and then neurodegeneration. And I think that there's merit to that in the lab setting. Again, very hard to nail down in human clinical trials, and also with very broad exposures to things like HSV, where if you're looking at an 80-year-old who has a high risk of Alzheimer's disease, they have a much higher risk of having HSV throughout their lifetime, about 80%. Not 80% of 80-year-olds have Alzheimer's disease. The number is closer to 25%. And so it's that is an example of something that, it makes it hard to know, what exactly is going on, because it is so widespread. And so I think that, again, an important direction, but we need to become more specific in our exploration of that as an actual target for treatment.
Wrap-up question, one I'd like to ask people in your position, lots of knowledge, lots of attention on this issue. How do you live? What lifestyle choices do you make to minimize your risk?
Sure. So I won't speak for myself. I'll just speak for generally what we know in terms of evidence and benefit. Number one and number two are going to be aerobic exercise on a regular basis, and a Mediterranean diet or variations of it have been shown to either slow down progression of mild symptoms or prevent them from happening. Multiple studies showing that. And so those are the top two recommendations. After that, there is evidence from a recent clinical trial a few years ago, the Sprint Mind trial, that looked at aggressive lowering of blood pressure to a target, a systolic target below 120 in individuals who are in their late 60s. In terms of potentially preventing development of either mild cognitive impairment or dementia. And there was about a 20% reduction of developing mild cognitive impairment. So aggressive control of blood pressure, as long as, of course, your primary care thinks that it's safe for you to do that. After that, we get a little bit thinner in terms of the evidence, but there's some evidence that sleep, continuous sleep for 7 or 8 hours, where you get into deep wave sleep. That's restorative sleep that we know can reduce amyloid plaque burden in the brain. That could be helpful. And then we get even thinner, so I'm going to stop there, because the evidence is not as supportive. Not necessarily because things don't work. It's potentially because they have not been tested or harder to prove.
I can't thank you enough. Appreciate sharing all you know about Alzheimer's and what the future looks like. Appreciate it. Thank you, Dr. Gad Marshall.
My pleasure. Thanks for having me.